So in this session, we'll be dealing with the gross anatomy of the kidneys. Kidneys are located retroperitoneally on the post-abdominal wall. So vertebral level corresponds from T12 to L3. So they occupy epigastrium, hypochondrium, lumbar and umbilical regions. Right kidney is lower than the left kidney due to presence of liver on the right side. You can see here the vertebral level corresponding with T12 to L3, and you can see here this particular left kidney is slightly higher and right kidney is slightly lower, and this is the transpyloric plane which is passing through the hilums of the kidney. So it is passing through the upper part of the hilum of right kidney and it is passing through the lower part of the hilum of the left kidney. You can see the kidneys occupying the epigastric, hypochondriac, lumbar and umbilical regions. So upper pole of the kidney is 2.5 centimeters away from the midline, whereas hilum is 5 centimeters away from the midline, whereas lower pole is 7.5 centimeters away from the midline. So that means upper pole is closer to the vertebral column than the lower pole. So transpyloric plane passes through upper part of the right kidney hilum and lower part of the left kidney hilum. So if you observe, these are the relative distances of upper pole, hilum and lower pole of the kidney: 2.5 centimeters, 5 centimeters and 7.5 centimeters from the midline. So there are two ends, the upper end and lower end are the upper pole and lower pole. And there will be anterior surface and posterior surface, and there will be lateral border and medial border. So approximate length will be 11 centimeters, width will be 6 centimeters and thickness will be 3 centimeters. Weight will be 150 grams in male and 135 grams in female. The upper pole, it is thick, round and lies closer to median plane and related to suprarenal gland, whereas lower pole is thin, pointed, lies far from the median plane as confirmed from the earlier diagrams. So anterior surface is convex, faces anterolaterally, whereas posterior surface is flat and faces posteromedially. The medial border is convex above and below and concave in the middle where hilum is present, showing anterior and posterior lips. The lateral border is convex throughout. So in the hilum of the kidney, this is very important. From anterior to posterior, there will be renal vein, renal artery and pelvis of the ureter. So there will be an additional posterior segmental artery which will go behind the pelvis of the ureter. So from anterior to posterior, what you have to remember is vein, artery and pelvis of the ureter. So renal artery, renal, you can see here, this is the renal vein, the anteriormost structure. Then you can see the intermediate structure is renal artery and the posterior structure is the renal pelvis. So you can see it is present at the middle of the medial border. Presence is it like hilum transmits the following structures from before backwards: renal vein, renal artery and renal pelvis. That is the pelvis of the ureter. So if you see the relations of the anterior surface of the kidney, so on the right side you can see it is related to suprarenal, duodenal and colic areas. These three are non-peritoneal, and here you can see the hepatic area and jejunal area which are peritoneal relations of the right kidney. And here if you observe again, suprarenal, pancreatic and colic areas, these three are non-peritoneal, and the splenic, gastric and jejunal areas, these are the peritoneal relations of the left kidney. So it is the revision of the same thing. The right kidney is related to right suprarenal gland, second part of duodenum and hepatic flexure of colon. These three are non-peritoneal. The right lobe of liver and jejunum, these are the peritoneal relations. Left kidney is related to left suprarenal gland, pancreas and splenic vessels and left colic flexure. These are non-peritoneal, and the peritoneal relations are spleen, stomach and jejunum. So spleen and jejunum are covered by peritoneum of greater sac, whereas stomach is covered by peritoneum of lesser sac, where it is related to kidney. So these are the posterior relations of kidney. So if you observe here, in the upper part you can observe this is the diaphragm, and there will be 12th rib related to the left kidney, whereas 12th rib related to the right kidney, 11th and 12th ribs will be related to the left kidney. And you can also see in the lower part, you can see from lateral to medial side, transverse abdominis, quadratus lumborum, and psoas major muscles and their covering fascia. Psoas fascia, the anterior layer of thoracolumbar fascia, and there will be fascia transversalis. And you can also see these following structures like subcostal vessels and nerve, iliohypogastric nerve, and ilioinguinal nerve. You can see here on the left side, the posterior surface is related to 11th and 12th ribs, whereas on the right side, it is related only to the 12th rib. You can see the relationship of three muscles, the psoas major, quadratus lumborum, and transversus abdominis. So upper part related to diaphragm, costodiaphragmatic recess, 11th and 12th ribs on left side and 12th rib on right side. Lower part, psoas major with iliopsoas fascia, quadratus lumborum with anterior layer of thoracolumbar fascia, and transversus abdominis with fascia transversalis and paranephric fat. Between quadratus lumborum and thoracolumbar fascia, the following structures, as I've shown in the earlier diagram, the subcostal vessels and nerve, iliohypogastric nerve, ilioinguinal nerve, and fourth lumbar artery on right side only. So now you can see the coverings of the kidney. From outside inwards, it will be the paranephric fat. Here you can see this is the paranephric fat, and then renal fascia. You can see this is the renal fascia. So this is the anterior layer called as fascia of Tolles, and this is the posterior layer called as fascia of Zuckerkandl. And here this is the space of Zerota, and here you can see the perinephric fat, and this will be the renal capsule. So from outside inwards, it's the paranephric fat, then the renal fascia, then the perinephric fat, and the true capsule of the kidney, the renal capsule. So this is the vertical disposition. You can see above both layers fuse, then split to enclose suprarenal, then becomes the suspensory ligament of the suprarenal gland. Whereas below, both layers are not fusing. Few authors believe that both layers will fuse around the ureter. Some authors believe they won't fuse. They just get lost in the pelvis. So here you can see the renal fascia, the anterior layer, others called fascia of Tolles, and the posterior layer, others called fascia of Zuckerkandl. So this will continue with the psoas fascia here and gains attachment to the vertebra. So here the anterior layer will cross to the opposite side and continues with the similar anterior layer of the renal fascia. Okay. So both together we call it as fascia of Zerota. The anterior layer is called as fascia of Tolles, posterior layer is called as fascia of Zuckerkandl. Both together called as renal fascia of Zerota. And this space is called as space of Zerota. Between the true capsule and the renal fascia, this space is called as space of Zerota, which is having perinephric fat. So behind this renal fascia is the paranephric fat, whereas between the renal fascia and the renal capsule is the perinephric fat. So fibrous capsule formed by condensation of fibrous connective tissue of the kidney, closely invests the kidney, readily stripped from the kidney, but if kidney is inflamed, capsule gets adhered to the kidney and cannot be stripped. So perinephric fat, it's a layer of adipose tissue. It fills the space inside loosely fitting sheath of renal fascia, enclosing kidney and suprarenal gland. So inside the renal fascia, we'll find perinephric fat, but the same perinephric fat is outside the renal capsule. So in debilitating diseases, there will be loss of this layer, so which will cause downward displacement of the kidney, which results in kinking of ureter. Renal fascia, anterior layer fascia of Tolles, posterior fascia of Zuckerkandl. Superiorly, after covering the kidney, two layers unite, then split again to enclose suprarenal gland in a separate compartment. Later, the two layers reunite and continue a suspensory ligament of suprarenal gland and becomes continuous with the diaphragmatic fascia. Inferiorly, two layers remain separate and enclose the ureter. So when we trace it horizontally, the medially anterior layer passes in front of kidney and renal vessels and merges with connective tissue surrounding aorta and inferior vena cava. The posterior layer passes behind the kidney and is attached to the fascia covering psoas major and quadratus lumborum. Literally, two layers unite and become continuous with the fascia transversalis. Paranephric fat, it is a layer of fat lying outside renal fascia. It fills paravertebral gutter and forms a cushion for the kidney, more prominent in the lower part. So macroscopic structure, you can see here, this particular part will be the renal sinus, this particular part will be the renal substance, which is divided into outer cortex and inner medulla. So inner medulla is having these renal pyramids. So renal pyramids are triangular or conical. You can see this is the renal papilla. So this is the base of the renal pyramid, and this particular part of the cortex along with the renal pyramid, we call it as the renal lobe. So between the renal pyramids, you can see these are the renal columns. And here if you observe, the medulla is projecting into the cortex as the medullary rays. And if you observe, this is the intersegmental artery, this is the arcuate artery, and this medullary ray with on either side interlobular artery. So between the two interlobular arteries along with the medullary ray, we call it as renal lobule. So if you see here, between the two renal columns, so whatever is present, that is the renal medulla, sorry, renal pyramid along with the cortex covering it. This forms the renal lobe, whereas a medullary ray between the two interlobular arteries. So this particular region we call it as renal lobule. So renal lobe, renal lobule. And if you properly observe, these arcuate arteries are not anastomosing with each other. These are end arteries. So this is a interlobar artery, this is an arcuate artery, this is interlobular artery. These are the medullary rays extending into the cortex. You can observe here, this is the cortical nephron and this is the juxtamedullary nephron. Juxtamedullary nephron is at the junction of cortex and medulla, whereas cortical nephron is in the more superficial part of the cortex. You can see this is the glomerulus, the Bowman's capsule, proximal collecting tubule, the loop of Henle, distal collecting tubule. Then you can see this will be the junctional tubule, this will be the collecting tubule, and these are the ducts of Bellini, which will open at the apex of the renal pyramids, that is the renal papilla. And you can observe here, these are the minor calyces which are really receiving the renal papilla, which join to form the major calyx, which will open into the pelvis of the ureter. This is the macroscopic structure of the kidney. So outer cortex located just below the renal capsule and extends between renal pyramids as renal columns of Bertini. So this is the renal columns of Bertini. This is the outer cortex. This is the medulla. So inner medulla, it has 5 to 11 dark colored conical masses called renal pyramids of Malpighi. The apexes of the pyramids form renal papillae which invaginate into the minor calyces. Renal pyramid along with its covering cortex forms the lobe of the kidney. Renal sinus, it is the cavity of considerable size present within the kidney. Contains greater part of the renal pelvis, renal vessels, lymphatics, nerves and fat. It is lined by continuation of the true capsule of the kidney. Renal pelvis divides here into 2 to 3 major calyces which further divide into 5 to 11 minor calyces. So now you can see different parts of the nephron. This is the Bowman's capsule, this is the proximal convoluted tubule, this will be the distal convoluted tubule, this will be the junctional tubule, this will be the collecting tubule, and this is the collecting ducts of Bellini. This is the loop of Henle. This will be the descending limb, this will be the ascending limb. So nephron, it is the structural and functional unit of kidney, 1 to 3 millions. Consists of glomerulus and tubule system. Glomerulus formed by afferent and deferent arterioles covered by the Bowman's capsule. The tubule system is having the PCT, loop of Henle, DCT, junctional tubule, collecting tubule, and collecting ducts of Bellini. Histology will be dealt in detail. So now coming to the blood supply of kidneys. The renal arteries are the branches of abdominal aorta, supplies the kidneys, one renal artery for each kidney. In 30% of individuals, there will be access to renal arteries to the upper pole or lower pole of the kidney. Average flow in renal arteries is 1 liter per minute. So renal artery passes behind the renal vein in the hilum of the kidney. Renal artery divides into anterior and posterior divisions. The anterior division supplies the apical, so upper, middle and lower segments of the kidney, and posterior division supplies only the posterior segment of the kidney. The branches supplying the segments are called segmental arteries. Segmental arteries, after supplying renal sinus, divides into lobar arteries. You can see here. This is the renal artery dividing into anterior division, posterior division. So you can see this is the posterior division continuing as the posterior segmental artery. The anterior division dividing into apical branch, upper branch, lower branch, and this is the lower branch. This is the upper and anterior, and this will be the lower and anterior branch. So accordingly, the renal vascular segments are classified like if you see, this is the apical segment, upper and anterior. The lower and anterior are called as the middle segment, and this is the lower segment. So here this is the posterior segment. So you can see this is the Brodell's line, which is a relatively vascular plane because the anterior and posterior segmental arteries will not cross communicate along this line. So this will be a relatively vascular plane, but still there will be venous communications. Through this Brodell's line, we can explore to remove the renal calculus with minimal damage. So these are the vascular segments, like from anterior aspect, if you see, this will be the apical segment, this will be the upper and anterior, this will be the lower and anterior, otherwise called middle segment, and this will be the lower segment. And from posterior aspect, you can see this will be the posterior segment. So here you can see from the lateral aspect, you can see this is the posterior segment, this is the upper and anterior, this is the lower and anterior, otherwise called as middle segment, this is the apical segment, and this is the lower segment. So the segmental arteries will divide into lobar artery will divide into interlobar arteries, which passes through the renal columns of Bettini. The interlobar artery divides dichotomously into arcate arteries at the base of the renal pyramids, which I have shown. So these arcate arteries gives rise to interlobular arteries. Afferent arterioles arise from the interlobular arteries and enter the glomeruli, which then reunite to form the efferent arterioles. Efferent arterioles form peritubular capillary plexus and around convoluted tubules. So this is the lobar artery, this is the interlobar artery, and this is the arcate artery, and this is the interlobular arteries. So which are giving afferent arterioles to the glomeruli, and from there comes the efferent arteriole. So there will be a lot of details in this. There will be major arterial circle, minor arterial circle. So discussing them, it will be beyond the scope of this lecture. So here you can see this will be the vascular Brodell's line, but it's not actually a vascular because there are venous communications here. The anterior segment will not communicate with the posterior segment arteries. So capillaries drain into interlobular veins drain into arcate veins drain into interlobar veins unite to form the renal veins from both sides drain into the infravena cava. The left renal vein will be longer than the right one because the left has to come from left kidney, cross the midline and reach the infravena cava. It will be passing between the abdominal aorta and the supramesenteric artery where there will be chances of compression. That's why the varicocele is more common on the left testis, on the left side. The lymphatics, they drain into para-aortic or the lateral aortic nodes. So nerve supply is from the renal plexus, sympathetic from the T10 to L1, whereas parasympathetic is from the vagus nerves. So this is one of the anatomical landmark to identify the kidney from post-abdominal wall. We call it as Morris parallelogram. We have to draw two horizontal lines. One is at the level of spine of the T11, the other is at the level of spine of the L3, and two vertical lines. One is 2.5 centimeters away from the midline, the other is 9 centimeters away from the midline, joining the two horizontal lines. So all the four lines together form the Morris parallelogram where the kidney lies. The center of the hilum lies approximately at the level of L1. So applied aspects, congenital anomalies will be dealt when we deal with the development of the kidney. For time being, we are just mentioning like lobulated kidney, aberrant renal arteries, congenital polycystic kidney, horseshoe kidney, and renal agenesis. And if you see the actual clinical things, which are due to pathological things like renal calculus, renal failure, renal cell carcinoma, renal pain, which is the loin pain, which we feel in the lumbar region, then renal transplantation. So if you observe here, this is a horseshoe-shaped kidney, one of the congenital anomalies where lower poles of kidney are fused anterior to the aorta and the infravena cava. So you can see here this is a polycystic kidney. So here you can see the lobulated kidney. So here you can see the renal calculi at different positions. So this is a specimen of renal carcinoma. And here you can see the transplanted kidney, which is kept at the pelvis because it cannot be held at the natural position, because all the four layers, only renal capsule is intact. There is no perinephric fat, there is no renal fascia, paranephric fat, all those things cannot be constructed, so they keep it in the pelvis. You can see the arterial vascular pedicle being established here. You can see the venous pedicle, you can see the arterial pedicle, you can see the ureter being transplanted to the bladder. Thank you.